Management of shock in severe acute malnutrition. Shock is a life-threatening condition in which there is impaired perfusion of the body's vital organs. In severe acute malnutrition, shock is commonly secondary to severe dehydration or septicemia, or both. Cardiogenic shock can also occur as a complication of overhydration or severe anemia. A patient with severe acute malnutrition and shock is a very high-risk patient and is prone to poor outcomes as a consequence of the condition and as a consequence of its management as well. Malnourished patients are easily prone to overhydration. Therefore, the accurate diagnosis, management, and monitoring of shock are paramount for a good outcome. The diagnosis of shock is made upon presentation of a lethargic or unconscious child with cold hands and feet. In addition, there is either or both of a rapid or weak pulse or slow capillary refill, which is a capillary refill time that is longer than 3 seconds. To check capillary refill, press the nail of the thumb for 5 seconds to produce blanching of the nail bed. Ensure that the nail is at the level of the heart. Count the seconds from release to return of the pink color. In children that are in the 2 to 12-month age range, a fast pulse is defined as a heart rate greater than or equal to 160 beats per minute. In children in the 12-month to 60-month age range, a fast pulse is defined as a heart rate greater than or equal to 140 beats per minute. The diagnosis of shock due to dehydration is made if there has been a history of fluid loss from watery diarrhea or vomiting, and recent changes in the appearance of the eyes have been observed. Shock due to dehydration is managed with intravenous fluids, preferably half Darrow's dextrose 5%, or if unavailable, use Ringer's lactate with 5% dextrose with 20 millimoles of potassium chloride added, or normal saline with 5% dextrose and 20 millimoles of potassium chloride added. Run at least 10 to 15 milliliters per kilogram over 1 hour. While waiting to put up an IV line, give Resomal as per nasogastric tube at 10 milliliters per kilogram per hour. Drip down when the child is conscious, when the pulse rate is returned to normal, or after 2 hours. Switch to Resomal per nasogastric tube and manage and monitor as severe dehydration. See the SOP on severe dehydration until pre-dehydration weight is achieved. If recent weight is not available, rehydrate until the weight deficit has been corrected. The weight deficit is equal to the weight in kilograms by the percentage dehydration by 1,000 grams. Management of septic shock. Give oxygen to all patients with septic shock. Give broad-spectrum antibiotics. Prevent or treat hypothermia. Give sugar water or glucose by mouth or nasogastric tube. There should be minimal handling of the patient. Do not transfer the patient unless there is appropriate critical care transportation. For incipient septic shock, give F75 by nasogastric tube. If there's developed septic shock, give a slow IV infusion of whole blood, 10 milliliters per kilogram over 4 hours, or 10 milliliters per kilogram per hour over 2 hours of 0.45% saline with 5% dextrose or Ringer's lactate with 5% dextrose. Monitor every 15 minutes for deterioration, especially for overhydration and heart failure. Keep an eye out for increasing respiratory rate, grunting respiration, increasing liver size, and vein engorgement. As soon as the patient improves, which will be shown by a stronger radial pulse or the regaining of consciousness, stop all IV intake, and continue F75 by nasogastric tube. The signs and symptoms of septic shock overlap with those of severe dehydration and hypovolemic shock. A careful history and examination is important to reach the correct diagnosis and treatment. Consider septic shock in the patient who fails to improve or deteriorates on intravenous dehydration for an hour in a child with the diagnosis of shock. In the absence of a history of watery diarrhea in a dehydrated patient with signs of shock, hypoglycemia and hypothermia can suggest sepsis. An edematous hypovolemic child with no history of diarrhea or vomiting. The management of septic shock. Please note that if blood transfusion is not readily available for a child who has not received IV fluids, give 10 to 15 milliliters per kilogram of half Darrow's dextrose 5% over 1 hour, or 10 milliliters per kilogram of fresh frozen plasma over 3 hours.